Everybody that comes to see me with eczema wants me to be able to tell them, this is the food driving it. If you take this out of your diet, you'll be better. We now understand that it really is more the opposite. Food allergies don't cause eczema. We're trying to keep food off the skin. Food in the mouth, early and often, food not on the skin.
This is the Transformational Life Consulting Podcast with Deepa Grandin, MD, where Christians like you get the practical support and tools you need to build your spiritual, mental, and physical well-being, and to guide you on your journey to health and wholeness based on evidence-based science and God's Word. I am your host, Dr. Deepa Grandin. The title of today's podcast is Defensive Strategies in Atopic Dermatitis or Eczema in Preventing Food Allergies in High-Risk Infants. Atopic dermatitis is the most common type of eczema. It's a long-lasting disease of the skin. Individuals who struggle with this condition experience dry, itchy skin that quickly becomes red, inflamed, and sometimes infected from the constant itching. This type of eczema affects more than 230 million people globally and continues to rise in prevalence. It is considered the skin disorder with the highest impact on quality of life and lost years of life due to the disease. So what causes atopic dermatitis? This is the question I constantly get asked in my practice. Patients want to know what they can do to make the skin problem go away forever and how can they prevent their children from getting this skin disease. The cause of atopic dermatitis is complex. There appears to be a combination of abnormality in the barrier function of the skin, abnormal function of the immune system, something we call dysbiosis or imbalance of the skin microbiome. So the skin microbiome is basically a distinct microbial community which consists of bacteria, viruses, fungi, and other microscopic living things that inhabit the skin. Other contributing factors are genetic susceptibility, along with environmental factors such as ultraviolet radiation, air pollution, household hygiene, just to name a few things. So as you can see, there's several factors that play a role into an individual manifesting this type of skin condition. Now, allergic diseases in general have grown in epidemic proportions over the years, and this is not a strange thing for any of you that's listening to this podcast. But more recently, we're especially seeing an alarming increase in the prevalence of food allergies. So while atopic dermatitis is often thought to be caused by food allergies, we now recognize an allergic progression commonly called the atopic march, where atopic dermatitis is the first step down the road towards other diseases such as food allergies, allergic rhinitis, and asthma. Research is now showing us that if we can take the necessary steps in adequately and aggressively treating atopic dermatitis, especially in high-risk infants, along with the early introduction of food allergens, we can actually alter how the immune system behaves. And if we can get pretty good at doing this, we can even prevent the development of food allergies. Today, I have the privilege of having Dr. Stuart Carr with us, and we will delve further into this very complex subject. Dr. Carr has been the Chief Medical Officer at Snow Asthma and Allergy in Abu Dhabi since January 2019 and has spent, prior to that, he was for 20 years in academic clinical allergy in Edmonton, Canada. He was the Associate Clinical Professor at the University of Alberta, a past president of the Canadian Society of Allergy and Clinical Immunology, and a reviewer for Allergy, Asthma, and Clinical Immunology, the Journal of the Clinical Society of Allergy and Clinical Immunology. His primary interests are pediatric asthma, food allergy, and eosinophilic esophagitis. Dr. Carr is currently involved in a Canada-wide collaboration examining the safety and effectiveness of oral immunotherapy for peanut and other food allergies in preschool children. Dr. Carr, thank you so much for taking the time to do this podcast. Can you tell us a little bit about yourself so we can get to know you a little better? What led you to pursue a profession in allergy and immunology?
Thanks, Dr. Deepa. I appreciate the very kind introduction, and hard to say a lot more after that, but I appreciate the opportunity to speak with you and your audience on this very, I think, very important and topical topic, because there's obviously been so much work and so many new developments in the areas of food allergy and allergy prevention over these last few years. So I think it's really exciting to talk about it. So as you mentioned, I'm from Canada. And I've only recently, over the last 5 years, relocated to the United Arab Emirates. And I was raised mostly in Edmonton, Canada. So I'll take the opportunity to say go Oilers as we prepare for Game 7 of the Stanley Cup Finals. Have to have that opportunity. But anyway, it's interesting. My path to allergy was absolutely not foreseen. I was very interested in pediatrics. And so I was lucky enough to train in pediatrics at the University of Manitoba in Winnipeg. And they happen to have a very strong allergy program. In fact, the head of the allergy department at the University of Manitoba was Dr. Estelle Simons, who was a past president of the American Academy of Allergy and Immunology, one of the few Canadians to have served in that role. In my medical school training, I think, as is common for many of us in medical school, I had relatively little exposure to allergy and immunology. We learn our basic immunology, the nuts and bolts of the science of it, but I didn't really get much exposure to clinical allergy. In fact, I don't think I ever met an allergist during my medical school years at the University of Alberta. And so despite allergies, as you've already mentioned, being an incredibly common phenomenon, in fact, the single most common chronic condition that affects people in the world, I had really no significant exposure to it. And being from out of province, being matched to the University of Manitoba, I didn't get to choose my elective in my first year of pediatrics. And so when I received my schedule, they had assigned me to a 2-month elective in allergy and immunology. And immediately I had flashbacks to first year medical school immunology lectures, which were dry and dense and very difficult to sort of wrap your head around. And I thought, oh my goodness, how am I going to stand 2 months of doing this? And again, I had no concept of what clinical allergy looked like. Well, the allergy team in Winnipeg is a fantastic team. And within days of starting the rotation, I just knew that this was an area that resonated with me and appealed to me. And that's with no personal experience. I personally don't have any allergic phenomena. My family is really allergy-free, frankly. And so again, I didn't really come. People ask me all the time, oh, did you have a lot of allergies? Do lots of people in your family? Is that why you went into this area? It really isn't. What I saw doing my elective was, first, I was dealing with really common problems that I had already been seeing as a medical student, as a trainee, as a resident, but were really poorly understood problems and often, either unrecognized or underdiagnosed, certainly often undermanaged, and patients who were very often suffering with impact on their quality of life, as well as their just health and having to go to the doctor frequently or being admitted to the hospital with asthma exacerbations or whatnot. And what I saw from these patients was, especially when you would explain to them, what was going on, something that again had not really ever been well explained to them before, was this sort of appreciation and the light kind of going on, where they understand sort of what's happening with them. And then when you would see them back in follow-up after you had, started some relatively simple treatment for them, whether it was for asthma or allergic rhinitis or atopic dermatitis, as we're going to talk more about today, they would come back, and the level of satisfaction, the happiness from the patients and their family was I had never experienced anything like that before. And I knew before I was finished that 2-month rotation, I knew this was the training I was going to pursue. And, I really never wavered from that. And I still, to this day, I still really enjoy that sort of satisfaction that you see when patients come back and they say, how much better they're feeling and how much more confident they are in managing these problems. And it's just an incredibly rewarding area to practice in, because you can make such a difference in their quality of life and their wellness. It's a really satisfying specialty. I mean, as you well know.
Yeah, I think that's so true. And it's, the medical schools don't focus a lot on allergy and immunology, which is a little surprising. And that's the reason why even the American Academy and the college in the US, they go the extra mile during the meetings to invite medical students to come on. And I think it's such an important topic to give these young doctors to be the opportunity to understand. That's extremely rewarding, like you said, because you can actually make a significant difference. And most of your patients are actually very young when they start manifesting, and you can change the trajectory of how diseases manifest as they grow older. So I think you've made some really good points with that.
Well, and when you're seeing especially kids with allergic problems too, you're not just seeing the kid, you're seeing the family, and the family is suffering, and when we talk about atopic dermatitis, if the child is not sleeping well because they're very itchy, then the parent isn't sleeping well, often the mom more than the dad, unfortunately, in our society. But and that level of disruption on the family is very impactful, and to be able to do something that helps that in people who have often been struggling for a long time before they got to see you. I mean, it's very rare that we're the first doctor they're seeing for these problems, and very often they're frustrated with the system and the approach, and they walk in and out with bags of different medication, but they're never, nobody ever really explains what's going on, and nobody really has those conversations about this impact, or even just hears and acknowledges the impact that it has for them. Sometimes that's, very, very important and validating.
Yeah, very true. So Dr. Carr, before we proceed with, getting into the details of the topic, we have a mixed audience of public and healthcare providers that listen to this podcast. So I'd like to start with some basic definitions so we're all on the same page. What is atopic dermatitis?
Yeah, so it's a great question, and I agree. It's always important. I do this with my patients in clinic, as I explain to them right away what it is we're talking about. So atopic dermatitis is a very specific type of eczema. A lot of people use the terms interchangeably. Eczema really is a descriptive term, and it means sort of dry, itchy, scaly rashes. And there's lots of different types of eczema. I explain to patients that, things like cradle cap, seborrheic dermatitis is a kind of eczema. Psoriasis is a kind of eczema. The allergies people get with metals, allergic contact dermatitis, and is a kind of eczema. And lots of people have very sensitive skin and may have a kind of irritant contact dermatitis. Atopic dermatitis is a very specific subtype of eczema. It's the most common, as you mentioned already, subtype of eczema. And it's really characterized by a very predictable and typical appearance morphology, so what we see on the skin, and distribution. So, for example, in babies, they often have it on their cheeks and abdomen, on extensor surfaces, the outer parts of their arms and legs. As children get older and go into, school age and adolescence and adulthood, it often shifts to involve more of the flexural creases, so the elbows and the knee creases and other skin fold areas. And by definition, it is very itchy. If it's not itchy, it's probably not atopic dermatitis. So there's other characteristics as well, but if you've got a recurring, relapsing and remitting itchy rash that is in these typical areas, then you've probably got atopic dermatitis.
Okay, yeah, I think that's very well explained. So now that we're going more into precision medicine, trying to personalize medicine for the individual, what is the difference between phenotype and endotype of atopic dermatitis? How does that help us personalize?
Yeah. So this is an important and really evolving area. I mean, it's so complicated in medicine because while we are trying to get into more precision and personalized care, at the end of the day, there's a lot of things that are still sort of basic care that needs to be applied to everybody with the condition, and then you can kind of get more into the fine tuning aspects of it. But broadly, when we talk about phenotypes and endotypes, phenotypes really refer to what you're seeing with the skin, in this case with eczema. So we know that there are some people who have kinds of eczema that really only affect their hands and feet. We talk about hand dermatitis or hand and foot dermatitis. Some people have eczema that is around their eyes or around their mouth, so periorbital or perioral dermatitis. There's people who have the classic, more extensive, especially flexural kind of eczema. There's people who have kinds of eczema where they get these sort of circular patches called nummular eczema. There are several other sort of subtypes based on the appearance of what we see. And then the endotypes really refer to the parts we can't see. So genetic variations, antibody levels. Are they making high levels of IgE? Do they have IgE, the allergic antibody against, Staphylococcus, one of the bacteria that's often on the skin? Do they have IgE against environmental allergens? And then there's a lot of other sort of factors, again, that you can't see, but you might be able to measure. Biomarkers are how we often refer to these, that may then impact the way we treat patients, especially as we're getting into newer treatment options, which, I know we're not really going to talk a lot about today, but, biological therapies that target very specific pathways, newer small molecules, again, that may treat, again, very specific endotypes of eczema. Most patients, they don't care as much about that aspect of it. That's really more for our sort of fine tuning the treatment. The phenotypes matter because they have different prognoses and different implications for risk of, developing other allergic phenomena, as you were mentioning earlier, the allergic march. And somebody who's just got hand eczema, I'm not going to be as worried about them developing sinusitis and asthma as I might be somebody who's got more extensive, especially flexural eczema from an early age. So the phenotypes help us characterize the patients. The endotypes will probably have a bigger impact on the precision management, especially as we move forward.
Yeah. I think that's very nicely differentiated. And these terminologies, while they may not be very broadly used, I think over time, it's something that, people are going to be hearing more and more about. And
absolutely.
Especially when they go visit the doctor. So it'll be good for them to be aware that, these things actually do exist. So now let's move on to something else a little bit more basic. What are food allergies?
Sure. So, food allergies, again, is a both common but also very complicated condition because, broadly speaking, food allergies refer to any adverse response to a food that you're ingesting that is based on your immune system responding. So if it's not being driven by your immune system, we really don't consider it a food allergy. And if you ask people about whether or not they have a food allergy, a relatively large percentage, about a quarter of the general population, believes that they have a food allergy, when in fact that number is certainly less than 10%. And depending on how you're looking at it, it's probably between sort of 4 to 8%, depending on ages and again, types of food allergy. And that's because a lot of times people think that any adverse response to a food may be a food allergy, when there are lots of different sort of food intolerances or just adverse food effects, but they're not mediated by the immune system. And the big difference is immune-mediated food allergies really have the potential to cause more serious symptoms. And there are some types that are, not as common as your sort of classic, potentially anaphylactic allergy to peanut or shellfish. There are other immune mediated types like celiac disease or non-IgE mediated food allergy. But the ones that get the most attention are certainly the ones that might cause a very severe reaction. So with the food allergies that we're really going to talk mostly about today, we're talking about foods that will cause relatively immediate symptoms within minutes to an hour of eating the food, and foods that will cause very consistent and reproducible symptoms. And that those symptoms may be on a spectrum. They're not always one specific symptom, but they will include things like hives or itchy welts on the skin, swelling, gagging, choking, trouble swallowing, trouble breathing, vomiting, diarrhea, stomach cramps, and any combination thereof of those symptoms. But again, they're going to happen very consistently with a specific food exposure. They're going to happen quickly with a food exposure. And they're also going to be self-limited. They resolve quickly. They don't cause chronic symptoms, again, with a very few specific exceptions. These are episodes that are rapid in onset, but relatively rapid to resolve as well.
Yeah, I think it is quite confusing for a lot of people, including physicians, because I've had patients come in with a laundry list of blood tests that's been done. And a lot of times it causes more harm than good. Because you have even young children avoiding unnecessarily all these foods that they're really not allergic to, but maybe sensitized to. And then you worry about them avoiding these foods and later truly having an immune-mediated reaction like you were explaining. So can you help us understand the difference between food allergies versus food sensitization, and why does that matter?
Yeah, it's really an important question. And honestly, if you were going to boil down the topic of food allergy to and allergy practice clinically around the issues of food allergy to one issue, this would be the one issue. So sensitization is a specific term that refers to the presence of antibodies that recognize a substance that you're not supposed to have antibodies against. And in this case, we're talking about foods. Sensitization is not to be confused with sensitivity. A lot of people talk about having a food sensitivity. A sensitivity is an ill-defined, largely ambiguous term that sort of can be used to equate some sort of intolerance or adverse effect. But sensitization very specifically means you've got antibodies, and in this case, we're talking about IgE antibodies against a specific food. That's actually very common, especially in people who have eczema or atopic dermatitis. A lot of people will have antibodies against the food. But one of the absolutely critical areas of food allergy management and diagnosis is the appreciation that sensitization to a food is necessary but not sufficient to cause food allergy. So the overwhelming majority of people who are sensitized, who have a positive skin or blood test, who have evidence of antibodies against a food, when they eat the food, they don't have any reproducible or convincing clinical symptoms. So they are not clinically allergic. You really cannot be allergic to a food, let's say peanut, unless you have those antibodies. So again, sensitization is necessary, but again, the majority of people who have antibodies against peanut do not react when they eat peanut. So really, the key for allergy assessment, allergy diagnosis, is that understanding that the clinical history is the cornerstone of making that diagnosis. Honestly, if that was not the case, if it was so simple as to, if you test positive to this food, you are allergic to this food, they probably don't need us. This could probably be managed by almost anyone. But we know the exact opposite is true, that the overwhelming majority of positive allergy tests are clinically irrelevant positives. And that doesn't mean a false positive. We often use the term false positive, but it isn't a false positive because those antibodies are there. They're real. The test is detecting them, but it's understanding the meaning or relevance of those antibodies. And once you understand that having those antibodies is not enough to confirm an allergy, then we can really put the focus where it belongs, which is on the story. So if a person is already eating a food without reproducible, obvious symptoms, then we know that they are not clinically allergic. They have oral tolerance, immune tolerance to the food, and they should keep eating the food irrespective of that test result. If the person has had a concerning history with that specific food, and then they have a positive blood or skin test reflecting sensitization, then they have a high probability of having a true allergy. So really, the story is the most important part.
Yeah. I think that's very nicely differentiated because history, like you're stressing, cannot otherwise explain whether this antibody that you're seeing really is something that you have to take seriously or not. And, that's one thing patients tell me all the time. I've been eating this food. Now they're telling me I cannot eat it, but I'm still eating it and nothing happens, so it's very confusing for patients as well.
Absolutely.
Yeah. And I think another common area of misunderstanding is that food allergies is causing the atopic dermatitis. And I'm sure you've heard this from your patients. I've heard it so many times. Which food do I stop, doc, so this rash never comes back? But now we do know that it's such a complex interplay of so many factors, like I had mentioned in the introduction. So, Dr. Carr, can you help us delve into these complex interplay a little bit better?
Yeah. So, as you said, it is complicated. Now, I'll admit that I try to boil it down as simply as possible for my patients because they get so many mixed messages. And some of the things that certainly impact eczema and atopic dermatitis, some of them we're still learning about and some of them are hard to do much about. And so I don't want to lose sight of the forest for the trees with my patients. But what I often say, my explanation for it first is, the first thing I say when I see somebody who's got significant eczema enough that they came to see me about it, is I ask them if anybody they've ever seen has really explained to them what eczema is and what's causing it as best we understand. And as I know you also experience, the answer almost always is no. And so I explain right out of the gate, the first thing I say is that the bulk of eczema is genetic, that it's a genetic inherited skin barrier defect. It is not being caused by some external factor that we're going to be able to identify and then modify to take away the eczema, that it really is genetic, it's in their wiring. Now, there may be aggravating factors. Everybody with eczema knows that they have aggravating factors. If they put on a wool sweater, they're going to start itching. And that's, very predictable and absolutely a real phenomenon, but it is not the cause of their eczema. Again, the cause is overwhelmingly genetic. There are other factors, but a lot of those other factors are genetic as well. Immune dysregulation and other factors that again are not something that we can necessarily modify. So I start by making it very clear right out of the gate that we're talking about an inherited genetic skin barrier problem. That's the cornerstone of eczema. And then when we start talking about food, because as you said, everybody that comes to see me with eczema wants me to be able to tell them, this is the food driving it. If you take this out of your diet, you'll be better. Most of them have already tried manipulating their diet, usually without much success. That's why they're there to see us. If it had been working, they probably wouldn't be there to see me. And I explained to them that years ago, so when I started my training, and we're going back now 3 decades, there still was a lot of thought that maybe food allergens were driving eczema. And we did spend more time talking to patients about trying to avoid certain foods empirically or in cases based on testing before we understood better the limitations of that testing. But we now understand that it really is more the opposite. Food allergies don't cause eczema, but there is growing data over the last 15 or so years that eczema causes food allergy. And when I say that, every time I have to pause for a minute, I watch their face just change, their eyes go agape, their jaw drops, and they say, and I stop and I repeat it. And I say, that's right. Food allergy doesn't cause eczema. Eczema seems to cause food allergy. It really is the other way around. And really, there's an excellent paper for anyone who's interested by Diane Campbell from Australia from about, it must be 12 or 13 years ago, that really explains this outside in versus inside out mechanism for food allergy and eczema that we really understand, and it explains it very nicely. So it's always able to, somebody can look that up if they're so motivated. But again, what we explain is, I'm not going to tell you a food that's going to fix your eczema. I am now worried because you've got eczema that you are now at increased risk for developing food allergies. So we have to talk about foods that may have caused symptoms for you. We have to talk about foods that you may already be avoiding, which, as you mentioned already, could potentially be the worst thing we could do in somebody with eczema. So we now understand that the optimal route by which we develop food allergy is exposure through that defective skin barrier. Years ago, we used to think that we knew babies, especially babies with eczema, were more likely to develop food allergy. And we used to think if we just avoided those foods as a precaution during those very important, those critical formative months, that we could potentially bypass that window where they seem to be more likely to develop food allergy. And look, this was based on theory that made some sense, because we've always known if you never take penicillin, you're not going to be allergic to penicillin. If you never get stung by a bee, you're not going to be allergic to a bee sting. You have to have exposure to drive allergy. So the thought was, look, if we just take these babies when their immune system is developing, when their gut is maturing, when they're in the highest risk window for developing food allergy, if we just don't feed them these foods, maybe we can skip that window and they won't develop the allergy. Well, what we didn't understand was that the exposure that was driving the allergy was not them eating the foods. It was skin exposure, which is unavoidable. You can avoid taking penicillin, but you can't avoid skin exposure to food. If we go into somebody's house and we vacuum the infant mattress, if we vacuum the carpet, if we vacuum the couch, we will find in the house dust food proteins, peanut protein, milk protein, egg protein, all of the common foods. Even in families that have actively been trying to avoid foods like peanut, you will still find measurable and significant levels of these proteins in their house dust. And we now understand that exposure to these food proteins through this defective skin barrier is the best way for the immune system to decide it's going to develop this allergic response and sensitize and make these antibodies that then cause trouble. What we've also learned is that oral exposure, especially early in life, is the optimal route by which we develop immune tolerance, and that balances that skin exposure. So unfortunately, our well-intentioned but misguided advice to delay the introduction of these foods in babies that were at increased risk was probably the worst thing we could do. And we sadly contributed. We mentioned in the introduction that there has been a significant increase in food allergy over these last decades, and evidence showed that our recommendations to delay the introduction of some of these common allergens was a major contributing factor to a doubling in peanut allergy in the Western world during my sort of training and early practice years, unfortunately. So, again, there's a great saying from Maya Angelou that says, do the best you can do with what you know until you know better, and then do better. And that's what we're trying to do now, is we're saying, okay, sorry, yes, we made a mistake with that recommendation, but we now know better. We understand these mechanisms better. And so we're really trying to do better.
Yeah. Yeah, I couldn't agree more. And do send me the name of the paper that you were talking about, because there is also another really great paper that was recently published in 2022 from actually the University of Athens and Johns Hopkins, that looks at the interplay between atopic dermatitis and food allergies. And because, it's a very complicated relationship. And they actually call it the dual allergen exposure hypothesis, where the sensitization, like you were talking about, the antibodies doesn't necessarily mean allergy. And when you're exposing it through the GI tract, oral cavity, it actually promotes tolerance at the very young age. But through the skin, it can even progress into food allergies. And that's where addressing the barrier function of the skin is very important.
Well, and just to follow that quickly, we also now know that in those babies who are in that balance, they're tolerizing, but they're sensitized, even if they have mild symptoms with ingesting the food, we might be able to push them into tolerating it well just by persevering with that oral exposure, that this is in flux at that age, and we might be able to give them tremendous long-term benefit by sort of helping guide them through that step when they're showing some mild symptoms, especially cutaneous symptoms like rashes around the mouth or face where the food is touching them. But that if we then take that food away instead, we just allow this sort of train to go down that path towards allergy in an unchecked way. So yeah, this is really a very fascinating area that's evolving, and our approach to it has really changed.
Yeah. So now that we're talking about, addressing the atopic dermatitis and being pretty aggressive, especially as soon as we recognize individuals are at high risk for it, how does the epidermal barrier dysfunction, and I know these are very technical terms, and I know you'll help us to understand these terms. So the epidermal barrier dysfunction, transepidermal water loss, these are things that, from a scientific perspective or clinical perspective, we see contributes to the way why people with atopic dermatitis, their skin behaves that way, and it makes their barrier weaker. And we know that it actually constitutes or precedes even the occurrence of the atopic dermatitis and food allergy. So how does that play a role?
Yeah, so transepidermal water loss, it really just refers to how quickly your skin loses water. All of our skin loses water. I mean, we're not, perfect that way for retaining water, but there's a spectrum, and studies have shown, especially some studies from a few years back out of Ireland, where they looked in the newborn nursery and measured the transepidermal water loss on newborn babies, and they showed that in those babies who were in the top third of water loss in that group of patients, those were the babies who were almost certainly going to go on and develop eczema. So as you said, even before the eczema is manifesting itself, even before you see anything in their skin, these babies are losing water quicker, again, reflecting that they've got some sort of barrier dysfunction. We now understand several of the genes that may be integral in causing water loss. Filigran's the one that we've understood the best, but again, there are many other genes that can play a role with this. And again, this operates on a spectrum. The problem with this is obviously we don't, at least currently, routinely measure transepidermal water loss in newborn babies, and we certainly don't monitor this. This is really more in research and sort of mechanistic studies right now. However, I can foresee a future where this is something that we're able to look for more directly in our patients, especially ones who maybe have a strong family history of allergic phenomena in the family. But what it tells us is there are ways to potentially identify these patients. I saw some data again, actually at the European allergy meeting that I was just at last month, where they were also doing a skin swab in high-risk babies and looking for certain proteins that are either expressed more or expressed less, depending again on their sort of genetic predisposition, and trying to create a composite score that would identify the kids at highest risk of developing food allergy. And again, in a very preliminary research sort of model, they were able to say, between things like transepidermal water loss and these sort of molecular expression scores, they were able to identify the kids that were very, 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 very likely to develop food allergy as they get older. The problem is that doesn't identify the majority of people who go on to develop food allergy. And same things with the transepidermal water loss. If you target that specific group, whether it's, managing their skin, which we'll talk more about, whether it's, trying to prevent food allergy with early food introduction, you may have a tremendous effect on those individuals, but it's still only going to represent a small percentage of kids who go on to actually have food allergy. So these may put them in the highest risk groups for developing food allergy, but there's lots of other kids who also go on to develop food allergy who we currently can't identify well. So until we have sort of a more broad way of identifying who's got either relevant genetic or barrier defects that are identifiable, I guess, we kind of are still better off trying to come up with broader approaches to have the greatest impact on a population level. And so I think a lot of the things that we're trying to focus on currently really do have that sort of broader effect, rather than, if you've got gene X or if you express molecule Y, because we'll end up missing too many people with those sort of approaches currently.
Yeah, I think they definitely will play a role with stratifying, like you were mentioning, the really high risk individuals. And, even with the filaggrin, which is the most common mutation that we know about, those are still the minority. So we still have a lot of work to do in that area. Now, can a food elimination diet in those who have like established food allergies have a beneficial effect on atopic dermatitis?
Yeah, so, this is such a complicated question. First of all, what I always say to patients, again, who come to see me, and again, lots of the patients I see with atopic dermatitis do have a history of food allergy. That's not uncommon. It's not the majority of patients with atopic dermatitis, but again, I'm going to see a biased representative sample, and certainly it is not uncommon for patients that I see with atopic dermatitis. I was seeing a young boy today who has a history that's quite convincing for immediate food allergy. The problem in that case is he's already avoiding that food. When you have a true IgE-mediated food allergy, you're already avoiding the food. You already know that you can't eat that food because you have immediate concerning symptoms that make it frankly impossible for you to eat the food. So I'm not going to help you any further by telling you to avoid the food that you're already avoiding. So if somebody has an already established food allergy, whether they've been diagnosed or not, they're avoiding the food because they have reproducible, consistent symptoms when they eat the food. They're already avoiding it before they come see me. Now, are there a subset of patients who might benefit by avoiding certain foods that they weren't able to identify from their history, again, even irrespective of any allergy testing? That's controversial. There are at least case reports of some patients who, if they take away a few common food allergens, whether it's milk or wheat or egg or soy, they report benefit. It's hard to reproduce that in clinical studies. But what I always say to patients is, if they're very worried about the possibility that they might have a food allergy and they want to avoid a food empirically, I'm not going to tell them not to do that. But what I'm going to emphasize is keep that short. Avoid it for 2 or 3 weeks. And if you don't see a significant difference, get the food back in your diet right away. If you do perceive an improvement, I would still encourage them to return the food to their diet because it may be coincidental, it may be a placebo effect. They should return the food to see if there's a worsening, and then they should repeat that a couple of times to look for consistency. What should not happen, and you alluded to this earlier, is that they take a food away, a staple food like milk or egg, out of their diet for a prolonged period of time because they may then lose immunologic tolerance and now develop an allergy where one did not exist before. And there are many case reports in the literature of patients who were taking a food like milk, it's most commonly milk, in their diet regularly without immediate symptoms, removed it empirically to see if it would impact their eczema. Controversial whether it made a big difference with their eczema or not, but when they retried the food months later, had immediate, potentially life-threatening reactions. So we have to be very careful. If a family is very keen or motivated to try a dietary restriction to see if it impacts the eczema, they must do it with some sort of supervision. They must do it with a structured plan, not to avoid it indefinitely or for a prolonged period of time. Otherwise, bad things might happen. And this is also really important where you mentioned patients who come with reams of previous testing, that if a patient has been eating a food without obvious reproducible symptoms, nobody should be counseling them to take that food out of their diet based on the test. They should be seeing somebody with expertise in food allergy who can help them sort of decode those tests and navigate this pathway in a way that isn't going to cause harm, because I've seen too many cases of what's called iatrogenic or doctor-caused food allergy because of inappropriate dietary restrictions in these patients. So is there a potential for benefit? I'm not going to say the answer is universally no, but it has to be done carefully.
Yeah, I think that's very, very, very wise advice. Because the sensitization versus true allergy can be very confusing, and the placebo effect we know is extremely powerful. So avoiding reintroducing just to make sure that's reproducible, that's very, very good advice. So what preventive strategies in atopic dermatitis patients have shown promise in managing and preventing food allergies?
Yeah, this is really, as I was saying earlier, where the money is. This is where the rubber hits the road, so to speak. We now have very good evidence that gives us some recommendations that we can make pretty broadly, pretty universally. They obviously apply most in patients who are at increased risk, patients who either already have eczema or patients who have already reacted to one food, and we're trying to make sure they don't develop other food allergies. But these are interventions that can also just be applied to the general population very comfortably and safely without us necessarily having to identify the patients that are uniquely at the higher risk. We emphasize them most in the at-risk patients. But what we've learned so far, the most important one is early introduction of common food allergens in babies that are at increased risk. But again, there's no harm in the early introduction of common food allergens in babies who aren't at increased risk. And by early introduction, we're talking about getting the most important food allergens. The best evidence we have are for milk proteins, egg proteins, and peanut proteins into the diet before 6 months of age. In babies who are already showing eczema or babies who are already reacting to a food, we now recommend certainly by 4 months of age, getting foods like peanut, egg, milk into their diet. Even in babies who are breastfeeding, there's evidence that supplementing with at least occasional but regular cow's milk-based formula supplements may help decrease the risk of developing milk allergy. And it's very clear that getting peanut and egg into the diet between 4 and 6 months in these babies is beneficial. A recent study out of Scandinavia actually lowered that down to 3 months of age for common food allergens and showed even greater impact. And what's really critical with this is that the longer we wait to introduce these foods, the less benefit you get. And that goes by month to month. Every month from 6 months on that we wait, you get less protective benefit from introducing these foods. So I now would encourage all families to be introducing foods like egg and peanuts, certainly by 6 months of age. But in the kids that we identify to be at higher risk, whether it's family history or personal history of eczema or other food reactions, certainly between 4 and 6 months of age. We would then advocate for introducing all of the other common food allergens in age-appropriate fashion, focusing on the foods most important to the family's diet from 6 months on. So that includes all of the different tree nuts, cashew, and walnut, and hazelnut. Sesame seed is an increasingly common allergen. And there are baby-friendly, family-friendly ways to introduce these foods: nut butters, nut powders mixed into cereals and yogurt and different textures that are baby-friendly. So that's where we've got the best evidence. For example, introducing peanut in that early window decreases the risk of peanut allergy by up to 85%. There are very few things we can do in healthcare that impact the risk of anything by 85%. So when we're talking about simply feeding a common food to an infant and decreasing the risk of allergy by 85%, that's a massive impact. Now, the tricky part of it is not only do you have to then get those foods in early, and for some families, they're nervous about it. We have to work to facilitate that. And that's not through a bunch of allergy testing. It may just be having them eat in our clinic to give them the confidence to do so. I had this conversation with a family today where one of their children has food allergy. They delayed introducing the food because they were nervous about it. They now understand that may have not been the best thing to do. They're expecting twins, in fact, and they're saying, okay, what can we do to get ahead of this? We're like, okay, introducing it early. And if you're not comfortable doing that at home, then we do that in the clinic, whatever it takes to give you that confidence to get the food into the diet. But once you introduce it, a lot of families have heard about early introduction. They've heard that it's a good idea to try foods like peanut early on, but in their mind, they think of it as a bit of a checklist. Oh, good, I've tried peanut. Oh, good, I've tried egg. Move on. Well, no, it's really important that it then gets incorporated into the diet. A study called the EAT study showed that if they were fed the food twice a week from an early age and continued to eat it at least twice a week, it was tremendously effective at preventing the development of food allergy. However, in the real world, what they saw is that many families had difficulty giving these foods twice a week consistently, and therefore it didn't end up having the impact that you would expect it to have, that the overall impact on food allergy prevalence had not dropped as much as you would expect, mainly because it was difficult to get these foods in and keep them in regularly. So those are areas we need to learn better ways to support our families in both introducing the foods and then maintaining regular exposure. So that's the one we've got the best evidence on. The other part circles back to the atopic dermatitis. So atopic dermatitis, again, allows us to identify the kids at higher risk to get foods in early, but we also are now understanding that trying to treat the atopic dermatitis well from an early age may be beneficial. There were a couple of studies 10 or so years ago that suggested that regular application of emollients early on may help prevent the development of eczema and may help prevent the development of food allergy. Now, those didn't pan out. When we did better studies to look at the role of early emollients, we didn't end up seeing a protective effect. However, what we are seeing is that early, aggressive, and I say aggressive, but I guess what I should really say is appropriate. But in these studies, it's the treatment was what we would sort of loosely consider aggressive treatment of the eczema itself, trying to restore the skin barrier with appropriate anti-inflammatory therapy of affected skin areas, was able to not only have a tremendous improvement of the eczema itself, but also has shown a benefit in preventing or lowering the risk for developing food allergies. So again, treating the eczema, primary prevention of food allergy through sort of, appropriate management, secondary prevention of the eczema itself. So the two areas that I focus on when I see young kids is reassuring the family that the anti-inflammatory treatments that we're recommending for their baby with eczema are safe and effective and will help the eczema, but may also help prevent food allergy. That's really important. And then proactively in counseling them to get the foods into the diet early and often to sort of give that oral tolerizing exposure. So working on the skin barrier as best we can, and then working on fostering oral tolerance as best we can.
Yeah. I think that goes back to everything we've just been talking about, the dual allergen exposure, why preventing epicutaneous sensitization with proper management, it's all of that kind of goes together. So thank you, Dr. Carr. You've shared a lot of great information with us. Is there anything else you would like to share with us before we conclude?
Yeah, so I think thanks, and thank you, Dr. Brandon, for the opportunity. I've enjoyed our conversation very much, and I hope it will be a useful topic for your audience. So the two things I think that I would want to emphasize, maybe three, briefly. One is, again, going back to what we were talking about with the dual exposure and the role of the skin barrier, is it's really important now to try to avoid food contact on skin. So our dogma right now is no food on skin. So we don't want to put it on the skin to see if it causes a problem. We don't want to put it on the skin, to treat eczema or whatever. There's a lot of odd sort of stories out there. We're trying to keep food off the skin, food in the mouth early and often, food not on the skin. So that's one. Two, if you're worried about the possibility of either having or developing food allergy, if you've got a baby who's got eczema, see somebody with expertise in this area. Make sure that you're not following sort of either dietary advice or over investigating unnecessary testing from somebody that doesn't really have any expertise in food allergy. Seek out somebody with pediatric allergy training and experience to make sure you're getting proper evidence-based and current advice. There's a lot of very outdated advice. And then lastly, very quickly, if your child, unfortunately, we do all these things as best we can. We're never going to have something that works 100% of the time. If your child ends up developing a food allergy, understand that we now have treatment options that may help them develop tolerance, like immunotherapy, which can be done in a variety of different ways, that have the greatest effect the younger the child is. One recent review suggested that for every month older the child gets with a food allergy, the benefits of oral immunotherapy may drop by as much as 7% per month of life. So again, not waiting until they're older, but speaking with somebody who's got, again, expertise and experience in these areas to discuss your options. It's shared decision making. What is the best approach for you and your family? But knowing that there's more on the table than just avoiding the food and hoping for the best.
Yeah, that's excellent advice. And now we also have Xolair that was approved in February that increases the success rate of oral immunotherapy.
Absolutely.
Yeah, so definitely see the experts and get good advice and, put your child up for success. So thank you, Dr. Carr. Thanks again for your time and all the great knowledge you shared with us. And we hope to see you in the future, in future webinars and podcasts with us. Thanks again.
Thanks. I appreciate it. Happy to be here anytime.